and it's a pleasure for me to provide an update on new anticoagulant agents. These agents span beyond stroke prevention and atrial fibrillation. The most exciting action has been in stroke prevention, but I'm going to go beyond that in this talk and talk about stroke prevention in AF, venous thromboembolism prevention in total hip and total knee replacement, and treatment of acute DVT. Then I'll give you a little appetizer for a very feisty debate we're going to have between two experts on the future of warfarin vis-a-vis these novel oral anticoagulants. So let's start by comparing warfarin with the new agents. The new agents have rapid onset. In other words, you take one of the new capsules and within 2 hours you are completely anticoagulated, whereas with warfarin it can take 5-7 days to be totally anticoagulated. The dosing with the new agents is fixed, and like most of the drugs that we take, it's not variable, and we don't have to do any blood tests to change the dose. There are virtually no food effects, so those who've been deprived of spinach and broccoli and other green leafy vegetables can eat as much as they want to their heart's desire when taking one of the new anticoagulant agents. Very few drug-drug interactions, no routine laboratory coagulation monitoring, and if you want to get rid of these drugs, they have a very short half-life. They're gone within a day or so at the most. There is no specific reversal agent yet for the novel oral anticoagulants. Most of them work against activated clotting factor 10, and Dabigatran is an antithrombin agent. It works against thrombin-activated clotting factor 2. AF is a great place to focus because it's the #1 preventable cause of stroke. And we predict that by year 2050, up to 12 to 16 million will be affected by atrial fibrillation in the United States alone. And it's our increasing survival after heart attack, due in large part to the types of systems that Dr. Jacobs has talked about and the type of drug progress that was talked about by Drs. Bott and Sabatine, and because of our increasing age, that as a country that helped explain the rising prevalence of atrial fibrillation. And what happens is that in the presence of atrial fibrillation, a thrombus hides in the left atrial appendage. I say hides because on a routine echocardiogram, you cannot actually visualize the left atrial appendage. And you have to do a rather uncomfortable test, a transesophageal echocardiogram, putting the probe into the esophagus, which is next to the left atrium, to visualize this thrombus. Well, let's talk about the RELY trial. This is a famous mega trial of more than 18,000 patients with non-valvular atrial fibrillation, and the name of the game here was to reduce the stroke rate. And this was a randomized controlled trial. About 6,000 patients were randomized to warfarin, 6,000 to Dabigatran 110 milligrams twice a day, and 6,000 to Dabigatran 150 milligrams twice a day. And the winner, Dabigatran 150 milligrams twice a day. This was the winner because it reduced the stroke rate by 34% compared with warfarin. It was superior to warfarin, and it received FDA approval. Now, you would think, as with most blood thinners until now, that if you're going to get fewer strokes from a new drug, you're going to have a payback with more bleeding. But that turned out not to be the case. To everyone's surprise and delight, the type of bleeding that we fear the most, bleeding into the head, intracranial bleeding, was actually reduced by 60% with Dabigatran compared with Warfarin. So here we have 34% fewer strokes, and we have a 60% lower head bleed rate with Dabigatran. The next drug to come along is Rivaroxaban, tested also in a 14,000 patient plus mega trial of Rivaroxaban versus Warfarin to reduce the stroke rate. What we found is that for those patients who were actually taking their drug as assigned, that Rivaroxaban reduced the stroke rate by 21% and appeared on treatment to be superior to Warfarin. However, that's not the way the game is played. There's a strict rule that once randomized, you're always analyzed according to your initial treatment assignment. And using the intention to treat model, which you could say is the kosher model, there was still a 12% reduction in stroke with Rivaroxaban compared with Warfarin, but this was not statistically significant. So Rivaroxaban has been deemed non-inferior to Warfarin. Importantly, the fatal bleeding rate with Warfarin, or the fatal bleeding rate, I should say, with Rivaroxaban was 50% lower than Warfarin, and intracranial hemorrhage was reduced by 1/3 with Rivaroxaban compared with Warfarin. Okay, now, I said these drugs, these anticoagulants, have applications that go beyond stroke prevention, atrial fibrillation. I mentioned also that AF is a bigger problem because we as a population in the country are aging, and part of aging means that the hips and the knees start to go and need replacing. There are about 1 million total hip and knee operations a year in the United States, total hip replacements and total knee replacements, and these patients are at high risk for DVT and pulmonary embolism. And Rivaroxaban, in the dose of 10 milligrams per day, is very effective and safe for preventing DVT and pulmonary embolism. It's given for 35 days after total hip replacement and for 12 days after total knee replacement, and it's FDA approved for this purpose. There's also the use of Rivaroxaban for treatment of DVT, and I'll talk about treatment of Rivaroxaban and PE in a subsequent lecture, but the idea with treating DVT is Rivaroxaban was tested in a dose of 15 milligrams twice a day for 3 weeks against enoxaparin injectable as a bridge to Warfarin. And what we found in this large trial of 2,400 plus patients with acute DVT is that the recurrence rate of DVT was reduced by 32% with Rivaroxaban. In fact, if there had been, I think, one additional patient in the Rivaroxaban group, Rivaroxaban would have achieved superiority to enoxaparin, bridging to Warfarin. As it is, Rivaroxaban is non-inferior. Then a separate study was done with Rivaroxaban, what's called the Einstein Extension Study. And here, these are patients who had received at least 6 months of anticoagulation after DVT treatment, and they and their clinicians were uncertain whether to continue indefinite duration anticoagulation. So they were randomized to Rivaroxaban or to placebo, and the Rivaroxaban group had an 82% decrease in recurrent DVT compared with the placebo group. Now, when these drugs were under development, some had said that warfarin would become a footnote in history. I don't think that's actually the case. I think warfarin will survive into the new era because it has demonstrated over the years excellent efficacy. It's inexpensive. It has a long track record dating back to 1954. So there are no secrets left about all the adverse things that it can do. We have entered sort of a very bad marriage with it. We know all the adverse effects of warfarin. On the other hand, centralized anticoagulation clinics can now maintain the time within the therapeutic range greater than 60%, and rapid turnaround genetic testing is making warfarin potentially the dosing even more accurate. Some of you I know here today have your own point-of-care self-testing devices, and you check your own INRs, and that certainly improves the quality of life and the quality of anticoagulation management. And recently, it's been shown for those few individuals who month after month have an INR smack in the middle of the therapeutic range, 2.4, 2.5, 2.6, they can be tested as infrequently as once every 3 months. The most recent data to come out with the rapid turnaround genetic testing is fascinating because warfarin for the first time breaks the 70% ceiling, which had been thought to be impossible to do, and the time within the therapeutic range exceeded 70%. I'm sure in the expert debate, we will be reminded that a 70% in most high schools is a C or a C- type grade. Now, there are some unresolved issues with the novel oral anticoagulants. There is not yet established methods of monitoring. The therapeutic ranges are not known. We don't have yet a specific antidote, though I can tell you they're around the corner. Management of bleeding is at least theoretically problematic. We don't have a 50-year history with the novel agents, so we need to have a lot of pharmacovigilance for long-term safety, and we don't have head-to-head comparisons of one new agent against another. On the other hand, now in 2012, we have tremendous new opportunities. We have available for prescription anticoagulants that have a virtually immediate onset of action with simplified, straightforward, fixed dosing. No need to get INRs checked. No drug-food interactions. A short half-life. We don't have to bridge patients any longer with enoxaparin prior to elective surgery or colonoscopy. And for acute DVT, and you'll hear for acute pulmonary embolism, we have for the first time ever the opportunity to offer completely oral therapy for treatment, and this might lead to health cost savings and more outpatient treatment. So the take-home points are that the novel anticoagulants improve medication adherence because of lack of injections and lack of blood tests for coagulation lab monitoring. And what we should see over the next few years are lower stroke rates, fewer major bleeds, oral monotherapy with the novel oral anticoagulants for DVT and pulmonary embolism, but on the other hand, warfarin will not disappear. Thank you very much.
And just to tie together Christian's talk with yours, we spoke a lot about the inertia that clinicians have towards anticoagulating patients at risk for stroke who have atrial fibrillation because of the risk of bleeding. And now we have some agents that are appearing to be safer and at least as effective, if not superior. Do you think we'll be able to overcome some of that inertia as a medical community?
Well, I think inertia is sort of infectious within the medical community. And Greg, you and I and others here, Dr. Sasahara, our mentor on this, have been working for years to overcome inertia for prophylaxis of patients against pulmonary embolism. You know, it took 10, 20 years to get to the point now where we do routine VTE prophylaxis for high-risk patients in the hospital. But I think it's going to be important for us to look forward and develop systems where we compress this time, because I don't think we can afford, I don't think America can afford another 10 or 20-year gap. And then we have to accelerate the time. We have to disseminate what we're talking about here throughout North America and really throughout the world, because we have a great opportunity. We don't want it to be a lost opportunity.
I think that's an important message. And we'll take 2 questions from the audience, the 2 gentlemen standing there, starting with Dr. Bigdeli.
Hi, so I'm Benut Bigdeli from Yale. Thanks for this fantastic talk, Dr. Goldhaber. I have 2 questions. One is whether you can comment on the off-label use of novel anticoagulants, and secondly, whether you see a future for novel oral anticoagulants in patients with mechanical heart valves.
Sure. Well, the second question is a little easier and less controversial. There are phase 2 studies that have started in Europe, specifically in Germany, with Dabigatran for testing to prevent thrombosis on mechanical heart valves. You know, the first question about off-label prescription of drugs extends far beyond anticoagulation. You know, as licensed practitioners, we have it in our jurisdiction to prescribe off-label use of drugs when we deem that's the right thing. My preference, though, is to work within the system, and I think what we should be pushing for is accelerated governmental review and licensing rather than circumventing the system. There are, of course, certain specialized circumstances where we will do off-label prescription, but I think we should keep those to a minimum.
Thank you very much.
Dr. Gabe?
You mentioned that there is no much drug interaction between the Dabigatran and the rest. Recent reports suggest that the case might be different regarding increased risk of bleeding for people like amiodarone and the Dabigatran. What's your opinion about that, especially now amiodarone is used much more commonly, and the AF, especially for atrial fibrillation?
There have been some theoretical reports, in some case reports of increased bleeding with amiodarone, but I don't think that the evidence is really in yet. I think that it is important to remember that with all the novel oral anticoagulants, whether it's Dabigatran or Rivaroxaban or Apixaban, which is not yet licensed for use, that we have the option of using a lower dose, one that's developed primarily for patients with chronic kidney disease, but we have the option, if we want to, if we see someone particularly frail or at risk, of picking that off-label lower dose if we're especially worried about bleeding.
Thank you.
Thank you, sir.